Hello and welcome. Thank you for joining us today for the last installment in our Autism and Primary Care Education series. This series is brought to you by the Ridge Meadows Division of Family Practice Child and Youth Autism Project in collaboration with pediatrician Dr. Anna Maria Richardson. The funding is provided by Shared Care Committee. My name is Dr. Murthy Korada. I'm a pediatrician in Maple Ridge in beautiful British Columbia. I'm also the specialist lead for this autism project. The autism project was started because the Ridge Meadows division received feedback from its members, which includes the family doctors and the nurse practitioners, about lack of clarity with diagnostic pathways for autism and the support system in the community. The pediatrician group in the community has been struggling as well to figure out appropriate resources for these patients and their families, both before diagnosis and after diagnosis. In many ways, the support system for these families has been fragmented and patchy. The interaction between various practitioners and other healthcare providers has been minimal. Our autism project is a perfect example where all the stakeholders, including the families themselves, were brought together to the table to find appropriate solutions to these problems. Our aim is to streamline the diagnostic pathways and support systems in the community by encouraging a dialogue between primary care practitioners, pediatricians, child psychiatrists, and also the additional healthcare providers. This amazing project has provided us with excellent options and solutions, and one of them is this education series. We are here today to delve into supporting these patients and families after the diagnosis of autism. We are also here to support you set up your practice and your clinic space appropriately for these families. Please join me in welcoming back Dr. Anna Maria Richardson.
Hi, welcome. I'm Anna Maria Richardson. I'm a community-based pediatrician giving you part 3 of a 3-part educational series mostly aimed at primary care providers around autism. So part 1, we talked about kind of my thoughts and ideas about autism. Part 2, we talked about how kids might present to your clinic and what to do. And now part 3, we're going to talk about what to do after the diagnosis. So that will be the focus. Okay, so a family has been waiting 2 to 3 years for an autism diagnosis. They finally have it and they come to your clinic, and really, what are the next steps, right? There's been so much wait and hope and expectation, and suddenly the process after becomes quite complicated. So I'm hoping to kind of walk through some of the things that should happen so you can help direct families and maybe some resources that you can turn to if you're not sure what to do. So when a QS, so a qualified specialist, completes their autism assessment, and reminder that under 6 is a multidisciplinary team, and over 6 it can be just one person. They'll be given a paper, and if it's at Sunny Hill or at BCAN, it'll be a BCAN paper, and if it's in the community, it'll be called a non-BCAN autism diagnosis. And so they'll come to you with that. So when all children who have a diagnosis of autism have access to CYSN, so Children and Youth with Support Needs worker. They'll be assigned to the family, to the patient, based on region, based on location. So Vancouver, Richmond, Ridge Meadows, Prince George, Terrace, Bella Coola, everybody has their own regional CYSN offices, and the worker there is supposed to help the family navigate the system. So the CYSN worker will complete the paperwork to set up the autism funding unit, so the AFU account, and they should explain the process to the family about what the next steps are. When a family receives an autism diagnosis, that first period of time, they're they may not remember everything that they've been told because a lot of information, there's a lot of emotions, there's a lot has been going on. And so a CYSN worker will give them the information, but they're not going to call back and check in and see like how things are going. So it's a voluntary service. So I recommend that families know who the CYSN worker is, and that you as a clinician maybe write it down. That way, when you do have questions, you can turn to that person and actually reach out to them directly. With access to CYSN, they also have ability, and we'll talk about this much later, about access to respite. That can be indirect or direct, and I will talk about it later. And just remember that that support is available. The CYSN worker, the structure in MCFD is CYSN worker, supported by a team lead, and then supervised by a DOO, a director of operations. So if you're having difficulty accessing supports, remember that you can ask to talk to the team lead as well. The autism contract, the AFU contract, is actually signed by one parent, and that can lead to challenges if the parents separate and one moves to one district or region and one to another. That one parent has access to the AFU and they kind of control the funds. So you can switch it over, but that takes a bit of work. And again, a reminder that the service is by region. And so if a family moves from, again, I'm in Vancouver, so I think Vancouver to Richmond, that file needs to be moved to Richmond. And so again, there's lots of administrative kind of barriers that can happen with the access to AFU. So a reminder that autism funding units for children under 6 get $22,000 per year, and 6 and older, 6 to 18, at $6,000 a year. And for kids under 6, they can only utilize that fund for people that are on the Registry of Autism Service Providers. So the RASP list is BCBAs, so Board Certified Behavioral Analyst, Speech and Language, SLP, OT, Physiotherapy. And just a reminder that BCBA is, again, a master's degree supervised with internship and supervision to actually learn behavioral analysis. And some people call themselves a behavioral consultant, and that can be different. So it's not better, worse. It just make sure that you know if you're talking about a behavioral consultant or a BCBA. They're two different things. The other important thing to remember is that having a child with autism or with profoundly impacting autism, the parent becomes a case manager as well, and that can become like quite a bit of overwhelming work. And so any support that you can give the family or the parent that's kind of doing the case management will really go a long way. So what can the funds be used for? So as I mentioned, it has to be somebody on the RASP list for under 6. I'll go through under 6 and then over 6. So under 6, the criteria are much more strict. Over 6, they open up a little bit. So every child requires a behavior plan of intervention, and that can only be signed off by a behavioral consultant, again, a British Columbia term, or a BCBA. And it's really important to remember that these need to be looked at and kind of updated frequently, because children in their under 6 period are rapidly changing, and a behavioral intervention plan from 2 years ago for a child who's now 5 may be the wrong intervention plan. The providers, again, must be selected off of the list, the RASP list. The only caveat to that is that family therapists or counselors don't have to be on there, and that is actually covered by the AFU. Parents as case managers can also claim $100 per month for managing the care of their child. And a reminder that 20% of the funds can also be used for things, I call them. Weighted blanket, iPad, sensory toys, tools, visual calendars, maybe the PECS program, and as well parent courses, which can really be like really helpful in terms of educating parents about how to, learning about autism, potentially learning about different expressions of autism. That up to 20% of the 22,000 can be included in that. And that even includes travel, which I think is pretty amazing. Computers, iPads are covered, one every 3 years, up to a certain amount of money. And I don't think they cover things like the protective covers or any of the apps that you need. So it's just the equipment. So for kids 6 to 18, as I mentioned, the AFU opens up, and it can be almost anything that you have a rationale for why you feel it would be beneficial. So of course, PCBA, SLP, OT, PT would be simple, but things like life skills or social skills program, tutoring, that's not part of the school program. I have lots of kids engaged in adaptive or therapeutic programming, horseback riding, skateboarding, karate, circus school, like anything that provides an adaptive program that you can find kind of a rationale what you're hoping to address with the program can be used. Registered dietitian can be used here, which is fantastic for kids that have fairly picky eating. The administrative fee goes down to $50 per month for families, but again, still 20% of that $6,000 can be used for equipment and for education and training. AFU rolls around every birthday, and so that means that you have your $6,000 for the year, or the $22,000. If you don't use it by the birthday, it disappears, and you get your New Year allocation. So a quick thing that you can do as a provider that's working with a family is just a quick reminder, like if they haven't used funds by the time the birthday is coming around, maybe that's the time to like buy equipment or supplies or enroll in a course or a class. So just to make sure that you utilize that. When parenting a child with complex needs, and potentially being a partner and parenting other children and working and, cleaning your house and going grocery shopping and cooking and doing all of the things that you need to do typically, when on top of that, you're a case manager for a child with complex needs, it can be overwhelming. One of the biggest supports that we can provide families is respite. And so it's just giving parents a bit of a break, a bit of support so that they can take a shower, and not have to worry about, if their child's going to be safe or not. So they can go grocery shopping, they can go for a walk. So respite can be family saving. And access to respite is going to be through the Child and Youth with Support Needs. So ask parents how they're doing. Ask them if they need respite. It is a hard thing to acknowledge and to ask for help. And so just giving parents an opportunity to agree with you that they may need extra help might be a really simple thing to do. So respite is divided into two kind of categories. There's direct respite, which means that the family directly gets money to pay somebody to support them. And then there's indirect respite, which means that the child will go to another home, a foster home, a group home, a resourced home. And so they're out of the home and the family doesn't get funding directly for that. Respite was, I think, developed with like the creation of MCFD back in the 90s. And so the funding is in 1990s dollars. And so it's $256 per month based on paying, $10 to $15 per hour. And so we know that currently providing respite for a child with complex behavioral needs, you're not going to be paying that. So it really doesn't work out to very many hours per month. The great thing though about the direct respite is that the family member can actually, you can pay your mom, you can pay your sister, you can pay your, a sibling to come provide respite. So it's really open to anybody. After COVID, they actually made changes to respite funding, and you can use respite actually to have someone come in and help clean your house even, to give you other ways of using that funding. And so again, the CYSN worker is in charge of the respite dollars, and parents, voluntary service, need to ask for it. Often they'll be told that the lists are long, you're on the list, we don't have enough funding. So as a clinician, again, you can do what you can, write a letter, advocate, call them that you really feel like this family would benefit from additional support. I've got patients, 6 years they've been on the list for respite. It's not nothing. So apply early. Remember to tell parents to apply early. And so with the directly funded respite, there is the baseline, and then there's enhanced respite that you can actually ask for as well. And so you're saying that the child and the family needs more support, and it will be, again, one kind of a individually determined how much that's going to be. It can be $350 a month, it can be $1,000 a month. It's variable depending on needs. Usually enhanced respite has a duration, and so it would be enhanced respite for 3 months or for 6 months, or it will have to be re-looked at every month. So you have to try to encourage or advocate for longer duration of respite, because every time it gets taken away, parents are made to go, again, plead their case, say how they're unable to, do the things they want to do, and it just becomes emotionally exhausting, and I think adds to the trauma. So as mentioned, there's the indirect respite as well. That would be kind of an escalation, and it can be a child can be maybe in a group home or a resourced home for 2 days, a weekend a month. And it can be anywhere up to 14 days per month that a child is in a separate home, to give the family time to then bring the child back. Every patient, every family I have worked with, their number one hope would be to be able to provide adequate support and care for their child in their own home. The fact that we have indirect respite is great, but in an ideal world, we would be supporting parents where they feel their child would be best supported, and that's usually in their own home, but we don't have that access or availability right now. So this is an option, indirect respite, up to 14 days per month. Anything over that, the parent needs to engage in an agreement with MCFD, with the Ministry of Children and Families. That's called a Special Needs Agreement, or an SNA. And that just means that you're kind of working more within MCFD and asking for more support, and that can be full-time out-of-home care. Again, I feel like families are not forced, but pushed into the position where this ends up happening, where in an ideal situation it would be at home, but a special needs agreement is available. Parents remain custodians, remain guardians of their child, are in charge of medical decision making, are in charge of all parenting duties, but the care is provided out of home. So that's for respite for supportive families. I think another thing that can happen after the diagnosis is like the treatment, the intervention. I think it's important to point out that we're not treating autism. We're not trying to get rid of autism. We're trying to support a child or a family to not be so, to be able to function a bit better. So I just, again, keep things simple. Kids need to do well at home, at school, and with friends, and with peers. It can be one person, it can be whoever. I'm not saying that everybody needs a huge peer group, but Kids need to be happy at home, at school, and with peers. So any intervention that we can do to support that, I think is great. But just remember that we're not trying to get rid of autism. I don't care if a child doesn't make eye contact. Like, we don't need to get rid of these features that I think are just like part of the great diversity of human beings. So current options for intervention are varied. Applied behavioral analysis, or ABA therapy, is often referred to as a gold standard. It is very controversial, and I will try to go through very little bit about the controversy. Self-advocates, again, are highlighting that you don't need to make people less autistic to make them great, to make them function, right? And so the idea that ABA therapy is to make people less autistic is kind of like the controversy. ABA therapy was developed in the 1960s by Lovaas. I think he had a big cohort of kids that he applied this like intensive intervention. I think it was 40 hours per week for a year. Current funding dollars are not going to get you that degree of intervention. And then he published this article in 1987 where he demonstrated that with this intensive intervention in the early childhood, under the age of 5, I think, there was an improvement in IQ. And so again, I think that can probably lead to discussion about how we measure IQ and what that actually means. But this is where ABA therapy came from. In this old, that nobody does, this type of ABA therapy, they used both repetitive and positive and negative reinforcement. And so when people currently are practicing ABA, nobody is practicing that old approach. So I'm open to any therapy that I think benefits a child and a family. So ABA currently, so the critiques are that, so there was punishment. It was very, very repetitive, so it was very tough on kids. It was focused on eliminating behaviors and eliminating difference. And so those are overall the critiques of old, no one does any more ABA therapy, or no one should be doing any more ABA therapy. But I think it's great that self-advocates have raised these concerns because it makes us more thoughtful about how we're doing intervention. So ABA therapists are the board-certified behavioral analysts, and they are usually the ones doing ABA therapy. So which option to choose? I mean, my approach is whatever the parent really thinks is best for their child. I think that I work with and I know just the most amazing BCBAs that do the most incredible work through ABA, and so I'm a real advocate of it when it's done well and properly and safely and thoughtfully and iteratively, so you're not implementing a plan from 2 years ago. But you might hear, DRI, so differential reinforcement of behavior, or floor time, or whatever works, whatever the family is happy with. The one thing is that the child should go willingly, happily to therapy. And if they're not, then that's not a good fit. Something I have come across a lot in my practice, I call them predatory practices. It might be a bit of a strong word, but I feel strongly about it. I think it's a bunch of people that are trying to sell a cure for autism. And first of all, again, I go back to the idea that you don't need to, autism's not something that you need to cure. It's a description of, it's part of people's identities. But there's a lot of practices out there, and you can look them up. They're everywhere. And I think they're unethical. I really think they're against a neuroaffirming approach, and I think that they provide false hope. They're expensive. They're not evidence-based. They're they're usually anecdotal. So just be careful when parents are asking about maybe something you haven't heard of. I, again, believe that the parent knows what's best for their child, and my job is to support the parent and the child in whatever therapy they're going into. I'm open-minded too. Potentially some of these practices might lead to, future different understanding about how to provide intervention. I'm open. But I just need to make sure that they're not harmful and they're not giving this false hope. There's a lot of conditions right now that parents will come, PANS and PANDAS is like high up there. So pediatric autoimmune neurodevelopmental disorder. It's this neuroinflammation is a big one right now. And again, I do think that there's something about inflammation and neurodevelopmental disorders, but I don't think that we can draw yet a one-to-one relationship, especially with treatment. But I'm open-minded. I'm very willing to be wrong. I'm very willing to have somebody tell me, nope, this is it, and I will go down that. So parents might actually come to you with questions about alternative treatments, and there's usually not a lot of evidence about them, but I actually maintain a really open mind. I know that I don't know everything, and I know that in the future we will know very different things. I just constantly remind myself, 500 years in the future, we're practicing the medicine of 500 years in the past. And so we're not bloodletting anymore. We're not using leeches. We're not, massaging humors, right? Because we've learned. And so I think that some of these alternative therapies might end up, as potential future therapies or interventions. So I'm open. I try not to get into arguments. I don't know. I want to make sure that things are safe. I want to make sure that there's no harm. I want to make sure that, maybe financially that families aren't being taken advantage of, but I'm open-minded. So things that people might come to you with are questions about neurofeedback. There's not a lot of evidence about neurofeedback, but again, it's not harmful. The microbiome or the metabolome I do actually think eventually we're gonna be learning the importance of that. And so that's like the bacteria in the gut, the bacteria that are living everywhere, the metabolites that they produce actually for sure interact with our body. And so how that interaction happens, I don't think we know enough about it yet. People come and ask about methylation is another hot topic. B6 or B12 supplementation is probably not going to cause harm. And you can monitor the levels. CBD is another big one. Again, I don't know. We have cannabinoid receptors in our body. Parents are often looking for what they call a natural medication, which I still think is a medication. I think that where you get it from doesn't make it better or worse. And so CBD, I don't prescribe it. I refer to clinicians that do. I have anecdotally found that maybe 1%, 2%, 3% of my patients do incredibly well on CBD. And it's not predictable who it's going to be. And so if families want to try it, I've got no problem. There's a lot of resources out there. And I think that you can access one of a video that we did on CBD with a student. When a child has a diagnosis of autism, they almost, I think 100% qualify for the disability tax credit. And so it's something that you can help families complete. They are long, they are cumbersome, they're 16 pages long. It's a non-refundable tax credit. You can backdate the date on the DTC back to the time of onset of symptoms, not the time of diagnosis. And so that can go back and they can get a good refund through that. I usually ask parents to fill out the majority of the disability tax credit on their own, and then they'll then they'll give it to me, and I just review it and make sure that I agree with what they filled out, to make it administrative paperwork in our job is probably the worst part of our job. And so anything we can do to help mitigate that, I think, is quite helpful. I get parents to help me. They fill in what they can, and then I read it and make sure it's okay before sending it off. There's a new digital version that is a lot more work because you have to complete the whole thing. And I mean, I think that parents know what the needs of their child are far more than I do. When children get a diagnosis of autism, the education system responds a little bit as well. And so children with autism should have increased access to supports in school. And so this is under the Ministry of Education. Children have what's called designations, and so they are A through T, I think, and each letter comes with a definition of what it is and the supports that kids get. And so autism gives kids a G designation in school, and with a G designation in school, they should have access to a one-to-one support, or SEA, a special education assistant, an education assistant, from bell to bell. This doesn't happen very often. And the reason for that is that because many children that have needs in school don't have designations, and so schools kind of scramble to provide support to as many students as possible. And so an EA that should be assigned to one student might be distributed to many. The funding for the school comes to the district, and then the district allocates to the schools individually. And so it becomes complicated because the designation should provide the child with a one-to-one support, but because of many children not having designations, the schools do the best they can. The designation itself, having a designation, one of those A through T, I might be wrong on the number of them, does allow a child to have an IEP, or an individualized education plan, completed, and it should be reviewed yearly by the school. That allows parents and the school to come together to maybe identify different outcomes for at the end of the school year. So maybe they'd be operating on a different curriculum. Maybe like there's a designation for ADHD, and so maybe if a child has ADHD, your IEP can simply be, need as many movement breaks as a kid wants, and you have that option. And so for a child with autism, the medical team can provide input, the parents can provide input, the teachers, the resource teacher all provide input about how to best support and meet that child's individual needs, right? It can be shortened school day, long school day, it can be sensory things, it can be tools and equipment, it can be all kinds of accommodation. So as mentioned, even though a child might have support needs and accommodation needs in school, they are often, at least in my patient population, don't have the supports they would require. And so children have a right to attend school in British Columbia, but they're often excluded based on behaviors. But really, I think it's based on a lack of appropriate supports within the school. So schools consider exclusion as a very strictly defined criteria. But many of my patients aren't allowed to go to school, but they're not considered to be school exclusion. Or they might be on like an alternate bell to bell. So they might attend 15 minutes per day, and then that can be reviewed weekly, but the criteria are ill-defined and not really achievable or obtainable without additional support in school. So inclusion versus integration. So inclusion describes the principle that all students are entitled to equitable access to learning, achievement, and the pursuit of excellence in all aspects of their educational programs. The practice of inclusion is not necessarily synonymous with full integration in a regular classroom and goes beyond placement to include meaningful participation and the promotion of interaction with others. So it just means that maybe even if a child's supported enough that they can attend bell-to-bell school, they might be not within the classroom itself, they might be in a sensory room. So just be really mindful about what that educational experience looks like for a child. If a patient is not allowed to attend bell-to-bell, I consider that to be a school exclusion. And there's a couple of supports available here. BC Ed Access, Tracy Humphreys, parent, put this together. And so any child that is excluded from bell-to-bell school, the parent can put in a report in the exclusion tracker, and she is actually doing the tracking. So encourage all families to fill out this form. Inclusion BC can be a help, and they advocate for inclusion. And then again, the Family Support Institute has an educational toolkit that really walks you through how to communicate best within the school district to encourage bell-to-bell access to education. I think one of the final things we'll be talking about, again, we've talked about how you actually get a diagnosis within British Columbia, but many people move here from other countries and they have already been diagnosed in their home country with autism. They don't need to go through the whole process again. You just have to have a form completed that says that there's been an equivalent assessment completed in a different country. So don't worry about those kids. Are much easier to be diagnosed. They don't have to get referred. You just have to make sure that they have completed in their home country an ADOS and an ADI, and then I think any pediatrician can fill out the form, or a qualified specialist can fill out the form. And that's it. So I just wanted final comment. This three-part series was something that was arranged. It came naturally, I think, out of a discussion I had with Ridge Meadows Divisions of Family Practice around autism and about how they can best support their patient population with autism. Through all of these discussions, we ended up developing a primary care toolkit that should be available for everybody to access, that really goes through everything that's actually on here already. So that support should be available, and thank you very much for your time.
Thank you, Dr. Richardson, for all your time and effort and providing us with excellent information. That was the final installment of our Autism and Primary Care Education series. If you did not have a chance to look at the previous 2 episodes, please take some time to look at them. If you have any questions about our Ridge Meadows Autism Project or the Autism Toolkit, please reach out to our Ridge Meadows division. We hope you enjoyed this series. Thank you for watching.